Hey, welcome to the last Falls Free Friday webinar of 2024. I'm Emma Harrington, and I'm the Director of Injury Prevention at Shepherd Center, and I will be helping to facilitate the session today along with our fabulous partners at iPrice. To start, we would like to go over a few housekeeping items. This presentation will be recorded and be available via the Injury Prevention Research Center at Emory, that's iPrice's YouTube channel. To reduce your background noise, we do ask that you keep yourself muted for the first portion of the session. Once we reach the discussion portion at the end of the presentation, you're welcome to unmute and ask questions. Please also feel free to use the chat box at any time. And if we don't have time to address all of your questions, we will be sure to get back to you with an answer. We would like to thank the entire Fall Prevention Task Force for their dedication and expertise in bringing you this virtual session today. This Falls Free Friday session will discuss managing medications as patient advocacy and reducing the risk of falls. I would like to introduce our speaker for today's session. Dr. Susan Miller is a professor of pharmacy practice and the Hood-Meyer Distinguished Alumni Professor at Mercer University College of Pharmacy. She received the Bachelor of Science in Pharmacy degree and the Doctor of Pharmacy degree from Mercer University. She has more than 45 years of experience as a clinician and academic pharmacist in the areas of geriatrics, medication therapy management, aging, and biomedical ethics, in addition to professional experience in providing elements of the pharmacist patient care process to geriatric patients in both the ambulatory and institutional care settings. Her many publications and presentations are in the area of consultant, long-term care, pharmacy practice, geriatric pharmacotherapy, medication safety, and curriculum development. Without further ado, I will pass it along to our speaker, Dr. Susan Miller.
Thank you, Emma. It's my pleasure to be here today to talk a little bit about some medications and how we as patients and care providers can be advocates in reducing the risk of falls, particularly in our older adult population. Emma has given my bio here, so this is what all she has just said. But the reason I got into working with older adults, and we're changing that language from elderly to geriatrics now to older adults. It was one of those happen kind of things. When I was in pharmacy school, I had a choice of a clinical, and I made the very informed decision to pick it based on who would be my preceptor or my teacher at that site, and it happened to be in a long-term care facility. And so I got to see the impact that a pharmacist could have on the lives of patients in the long-term care facility. And that kind of sparked my interest. And so I've been in that space, in that area for a long time. My original interest in pharmacy was to be a community pharmacist. So that's where my heart is in the community and working with patients in the community. And then it's changed to the older adult population. So let's get into the presentation or my information I have to share today. And I know a lot of people have a lot of questions and a lot of specific things about medications. And so this is going to be a broad topic, and I hope to hit kind of a lot of areas just to interest you or make you aware of some of the things. But the detail and the getting way in the weeds of specific drugs and things is not a part of this presentation. So what is a fall? Fall can be a season, fall. And I know with the audience and the group that's here today, we know that a fall is an event that happens or results in a person coming to rest inadvertently on the ground or a lower level than which they were. But we also need to recognize a near fall. And again, for this audience, probably that definition is well known as well. And so that's a stumble or an event where you lose your balance, and it would result in a fall if there was not sufficient recovery mechanisms. And some of those are inherent, those recovery mechanisms are inherent in us, but some of those things change as we age. But one of the more common things that people should keep in mind is the space that you're in, and how can you recover if you do have this near fall. And so I've learned in my life with working with falls for the longest time, always hold the rail when you're going up and down stairs. Kind of be close to the edge so that you can catch yourself instead of having that fall. So here's some statistics on falls, and I don't mean to make light of any fall or anything, but I thought this graphic would give all kinds of different little ways that we can fall, which people may not always interpret as a fall. And again, these statistics are here and they're out in the literature and in the public domain, and these things change. But if you look at the if you look at older adults, which of age greater than 65, about a third of those people in that population fall on a yearly basis. And then as we get older and getting to the older age above 80, that raises up to about 50%. So about half the population of that age can fall. Another statistics is there's been reported up to 3 million older adults visit emergency departments for a fall-related event on a yearly basis. And the math of that is one about every 18 seconds. 95% of hip fractures are caused by falls because quite often that's where you land, that's how you land. And so there's injury there. You probably have heard the statement made that sometimes the bone breaks first and then the fall. And okay, we can talk about that, argue back and forth, but the result is there's injury and there's been a fall. There's also been an increase in death rates from falls over the last 10 years. And you might wonder why that is. Sometimes then that's probably related to when you get back to was the fall reported, or did that come up in the discussion about the cause of death? And I think as a society and as a healthcare system, we are more aware of falls now and ask those questions. And I know now every time I go for a visit with a primary care provider or maybe anybody, they always ask, have you fallen in the last year? They always ask that question. And hopefully people are giving honest answers for that. Because if you do answer yes for that, then you're kind of put into a watchful waiting and a risk factor that maybe you could have another fall later on. And then obviously there's a cost. And of course, these are estimates just based on data that's out there. But not only is it a monetary cost, the cost for healthcare, but there's a cost to quality of life, which is probably not included in this. There's a cost to the family and actually the person that did suffer the fall. So not only is it a monetary cost, but it's a personal cost as well. So what can you do to prevent a fall or reduce your risk for a fall? And the first step is improve or exercise to improve your balance and your strength. And I am not an exercise physiologist, excuse me, I'm a pharmacist. And when you suggest someone to exercise to improve balance and strength, this needs to be guided exercise and with the informed consent and direction of your primary care provider or other healthcare provider. Just don't go out and try to start running marathons or walking upstairs or lifting things. I mean, it all needs to be in consideration, particularly with the older adult, in consideration of the other health-related conditions that they may have. Another thing to think about is having your eyes, your ears, and your feet checked. Our eyes and our ears both position us in where we are. We know where we are. We have a sense of what's around us, what's in front of us, what's behind us. And so we need to make sure our vision is at its best that it can be. And another thing I'm going to bring up in a minute would be when you put eye drops in your eye, that you might not think of that as putting you at risk for a fall, but that can change your vision exactly for the moment. It might be a little bit blurry, but you could also have some systemic effects from eye drops that may over a long run affect your or put you at risk for a fall. Our ears, again, we need to have our hearing to be at its maximum. So it's always good to have that checked. And then feet, when we're concerned about feet, we're concerned about a couple of things. We're concerned about arthritis and changes in the foot structure and function, maybe corns and calluses, about how they affect how we step and how we walk. And then in the diabetic patient, we're concerned about loss of sensation or nerve function. So again, they just don't know where their feet are in relation to where they are. Making your home safer. Again, we need to think about things about making sure that if you change levels in a home from one step or even a complete flight of stairs, that you're making those level transitions carefully. Throw rugs, slick floors, pets. We love our pets, but they can get underfoot. And so we need to make sure that we're aware of those and just have a safe home with not clutter around. The bathroom, anytime you fall in the bathroom, you're going to land on a hard surface. So the bathrooms need to be as safe as they can be to prevent a fall or reduce that fall risk. Now here, what we're here to talk about is the medications. So one should always have a current list of their medications, and I'm going to give you a resource towards the end of the presentation with that. But also have your healthcare provider review your medications with you. And several healthcare providers can do that. You can be your primary care provider, physician assistant, nurse practitioner, and a pharmacist could do that as well. And if you look at all of these people, the one person that you could go up to, most likely without paying and without scheduling an appointment 6 months out, is the pharmacist. So they are an accessible healthcare professional in the community. It's probably best to make a call just to set that up, just so that they make sure they have time for that. But you should know what your medications are and have them reviewed. So let's get into some definitions. I'm going to define a couple of different things just to be clear. When we talk about a medication, these are actually defined by the Food, Drug, and Cosmetic Act back to 1938. And notice they have the word drug in there. And we have changed that drug in society to the word medication we use more often, because drugs unfortunately have a negative connotation. People think drugs are bad, but they are medications. So we've changed that up a little bit to make it not so have such a negative effect. And there's the definition: articles intended for use in diagnosis, cure, mitigation or treatment, which means slowing things down, or prevention of disease. But another thing that clarifies or defines medications is they can affect structure or function of the body in man or animals. So structure or function. So I want you to keep that in mind as we move on to the next slide. And so evidently drugs that are on, or medications that are on the market in the United States, do have to be approved and go through testing. And that's a whole nother talk about how long that takes and what's required there. But like I said before, medications can prevent disease. So we talk about, maybe vaccines and other things like that. Manage conditions like blood pressure and depression and things like that. Improve functioning, where we can improve the function maybe of the heart or the lungs, and delay disability. So it's important to know that 3 of every 4 older adults, basically 3/4, take at least one medication that can be linked to falls. And I am not advocating anyone to just all of a sudden go off any medication that's mentioned today, or take that recommendation, because we all have to be on medications to manage our conditions. But if we have to be wise to know which ones are better or put the person at least risk for fall. So I want to make the difference with the dietary supplement. We just talked about what was a drug or a medication. And a dietary supplement, if you look, that act was 1994, the Dietary Supplement Health and Education Act, and we call it DSHA. And this defines dietary supplements as product other than tobacco, so they put tobacco out, intended to supplement the diet. So it's exactly what it says. It supplements. It doesn't replace, but it supplements the diet. And it contains either a vitamin, a mineral, an herb, or other botanical or amino acid. And what happens is people tend to put all these things together, herbals, vitamins, minerals, they kind of put them all together. And if you can get into, quote, the weeds and try to figure out these different things, but I think you can think about these together. But whatever a dietary supplement is, it's not supposed to be a replacement or a conventional food. But here's the difference. They are not intended to diagnose, treat, cure, or prevent. They don't undergo the same type of testing that medications do. And a lot of these drugs get on the market and are available. And if something happens and they're shown to cause problems, then they have to be proven harmful and then taken off the market. So it's a backwards process. So these people that supported this DSHA, they had a pretty good lobby because they got all their stuff on. It has to be taken off, whereas medications have to be proved to go on. But also, a majority of older adults consume at least one dietary supplement on a daily basis, and these can be purchased without a prescription. But I'm here to say too, these can have interactions. So it's important that when you're making your medication list, that any dietary supplement or anything you're taking should be on that list as well. So a little more on drug interactions. So National Institute of Health defines a drug interaction as a reaction, using their word, between two or more drugs, or a drug and a food, beverage, or supplement. So when you have a drug interaction, it's going to affect how the drug works. And sometimes these are good, but in the majority of cases, the drug interaction is not something that we want. So here's some examples. We have the drug-drug interaction, again, two or more drugs, and this is warfarin, which is the anticoagulant, and aspirin. They can have the same effect. So you can get an overreaction to the warfarin if the two are used together. A drug-food interaction is between exactly that, a drug and a food or beverage. And one that's very important and well known, when I speak to lay audiences of older adults, they always ask the grapefruit question. They always ask that. But atorvastatin, which we use to manage dyslipidemia, can interact with grapefruit juice. And what the problem there is, the pith and that white part of the grapefruit has got enzymes in it that can affect the way atorvastatin and some other drugs are metabolized. So you can get a higher level of the atorvastatin if you consistently consume that with grapefruit juice. And another one, again, that I think many people are aware of, the drug-condition interaction. So this would be pseudoephedrine, which we take for during the cough and cold season, and hypertension, because pseudoephedrine can raise blood pressure. So it's very important for us as caregivers and consumers to look at labels and ask questions to make sure that we know what is in the products that we're taking. So here's just a little graphic I found on the internet. So drugs, drug food, drugs with a natural product. And that's another kind of hidden danger. Many people think that because they can buy something without a prescription and it's a natural product, that there's no problem. No, it can be problematic because you can have some interactions there. So again, before purchasing and using any herb or natural product, you should have a consultation with your pharmacist or your primary care provider. So there's drug disease. I think we're all aware of drugs and allergies. And then there's a lot of new research coming out. We're learning more about how drugs can react with specific genes. I'm not going to cover that here, but there is several drugs that we have that once we know kind of what makes you up, then we know what dose of that drug that would be best for you. So why is risk associated with these? Well, with aging, medications and supplements can be processed differently. I think we all know they're not going to be metabolized as efficiently, and we may not eliminate them as quickly. And the more things you take, you've got more risk for side effects. One thing that I want to bring out is the hidden medications and supplements. So again, read labels, particularly if you're buying things over the counter, know what is in them. There's a lot of Tylenol in a lot of products, a lot of acetaminophen in a lot of products, and you can get too much acetaminophen if you're not reading your labels. Also, alcohol and tobacco alcohol can enhance the effect of a lot of medications, and tobacco can change the metabolism of drugs as well. So here's some side effects that can increase fall risk. We've got blurry vision, daytime fatigue or drowsiness, actually fainting or passing out, lightheadedness, loss of balance, muscle weakness, slowed reaction time, and trouble concentrating. So when you're looking at medication problem areas, looking for unnecessary therapeutic duplication. And so that's what we particularly do as pharmacists, and why it's important to have that med list, because you may be taking the same drug with different names. And this happens a lot in transitions of care. When someone is moving from the home to the hospital, maybe then back to home, something may be started in the hospital by a different name than they're buying it in the community. And so always do this checking for therapeutic duplication. We want to look for meds that can cause falls or confusion. We want to look for meds that can cause cardiovascular problems so they can change your blood pressure. NSAIDs, non-steroidal drugs, which are some of those are available over the counter. We use them for pain and lots of things, inflammation, but they can increase the risk of peptic ulcer or GI, gastrointestinal bleed. And then there's always opioids. Again, there's a lot of attention being paid to opioids now. And so are we on an effective dose? Are there other options we can be on? How many are given or prescribed at any particular time? So here we go again with what you can do. So you need to be an advocate for yourself as a patient, and then as a caregiver, as a professional, keep this in mind about what meds are there can cause a fall or put someone at risk for a fall. So the definition of an advocate, we can have professional advocates and we can have family advocates. So they help the patient communicate with healthcare providers so they get the information they need to make health care decisions. And I realize in patient encounters, you know, in the hospital or in the clinic setting or in the physician's office, you know, time is limited. And so sometimes those encounters are quick, but if we can provide written information, give time for questions, but also know, as far as medications go, refer patients to their pharmacist, and they can have maybe a little more time to go over the medications with them again. So some questions to ask when we're talking about this. Again, these go back to those symptoms. Do any of your meds make you feel drowsy, confused, foggy? Pricing, do you have difficulty obtaining your meds? And that's an interesting question because I know we all know the cost of medications can be stressful for many people. And sometimes they're going to change the dose of their medication based on their affordability, their ability to afford medications. Any symptoms you feel may be related to meds. So I was okay until I started taking such and such, and then this kind of changed. There's the falls question. There's the question about your home. How do you get along? Do you need any assistive devices like canes or a walker or special kinds of shoes? Do you have difficulty opening pill bottles or swallowing your medications? And are there any meds that you're on that keep you from meeting your specific goals? So I'm going to talk about some categories of meds that we need to specifically review, those that affect the brain, the blood pressure, and a few for blood glucose. And again, it's very common that older adults can be taking medications in all three of these categories. And so awareness is very important. So brain, we call those the psychoactives. And these can cause sedation or drowsiness, which obviously can lead to a fall. They can also worsen confusion, particularly in people with Alzheimer's disease and that may or may not have been diagnosed. And we have lists of medications that many of these drugs are on. And those of us that are in healthcare education across the spectrum are teaching this list. There's one that's called the Beers list, and it gives medications that may be problematic. And so your healthcare provider should be aware of that list. And this is not an absolute do not use list. It's just a use with caution list. So I think we know the benzodiazepines. Those typically have been prescribed to help people sleep or relieve anxiety. And they are effective, been around a long time, but they can be habit forming. Sometimes their use has been associated with developing memory problems, but definitely they're associated with increasing fall risk. But I also want to caution to say that it's dangerous to stop using these medications suddenly, that if a patient is on these, an older adult is on these, the decision to stop their use should be under what we call a controlled taper, so that we wind down a little bit and give your body time to adjust. So here's some example names. Then we have the non-benzodiazepine, the benzos and the non-benzos. So again, they were they maybe have shorter duration of action, maybe a little quicker onset, but again, for insomnia or sleep difficulties. And we call these the Z drugs because they have Z's in their names. But their use has been associated with impaired balance and impaired thinking in the short term, so kind of short-term thinking problems. And they are used only short-term. What's happened across practice areas, again, is they're really limiting the use of these drugs. There's a lot of limitation, particularly residents of long-term care facilities. There's kind of limits on how many can be prescribed and for how long of a period. So they're trying to put some clinical guidelines in place to help prescribers use these drugs in the best manner. These two drugs are used, doxylamine and diphenhydramine. They are also used as sedatives, and these two that are in the different font are available over the counter. So that's important to know that patients could be purchasing these. Benadryl, widely known, widely out there, but it's got a lot of problems in older patients. But anything with PM in the name, Tylenol PM, something PM, that's usually going to have diphenhydramine in it, which we need to be very careful with that, using that in our older adults. So moving on to the antipsychotics. These were originally prescribed for psychotic disorders, and sometimes they're prescribed to control difficult behaviors in dementias. And there's a lot going on in this area in as far as what the right dose is, when to use it, how long to use it, and what are the side effects. Sometimes we see these prescribed for depression, but at the end of the day, their use is associated with increased falls. One that's been around a very long time is Haldol. And what over the years, we've seen that all of these drugs are associated with adverse side effects. And now you're seeing some drugs come out that can mitigate those side effects. But you still see these used for psychotic disorders and sometimes to control difficult behaviors in dementias. But again, a good conversation with the healthcare provider, the family member, and the older adult can help come up with the best drug and the best dose. A newer group that we're seeing used a lot broadly are anticonvulsants or mood stabilizers. And these were originally prescribed for seizure disorders, but we can use them all the way across the board, including treating difficult behaviors in dementia patients. We also see them used to treat different types of nerve pains, but at the end of the day, they can lead to increased falls. Antidepressants are another brain group. So we use these to treat depression, obviously, but sometimes now we're using them to manage anxiety. And we have all different types of these. And some of these, like the Prozac, has been around a long, long time. Some of these others are a little bit newer. And some of these have better profiles, we call them, in an older adult than other drugs. But that's a decision for the healthcare provider, the prescriber, to make in concert with the other conditions that you're trying to manage in that patient. Over here, the tricyclic, most of these drugs in this class, these are the SSRIs, we call them, because they're working on this serotonin, one of the neurotransmitters. Tricyclics are old drugs, and they're not used so much anymore as antidepressants, but we are using those to manage nerve pain and sometimes to manage migraine headaches. So these are these in the italic font, those are your tricyclics. Trazodone was Desiril. That is a good antidepressant, but it's very sedating. So now how that one's being used more is in low doses as a sleep aid. But any of these drugs and all of these drugs have been associated with increase in fall risk. And then there's the opioids. Obviously, these are for treatment of pain, but I want to call your attention to the side effects. They can cause constipation, nausea, vomiting, euphoria, so they're kind of changing how you think, slowed breathing, and then there's that risk of tolerance and dependence. But now the CDC recommends that we look at narcotics as in that whole group of drugs that can put a person at risk for fall management. So you see all kinds of things are here. And there's fentanyl. Fentanyl is a very effective analgesic. And unfortunately, it's been hijacked by nefarious people. And, you know, that's the one that we're talking about in our current society, where there's a lot of misuse. They mix it with other things, and it can be problematic. But again, as care providers, we have to be careful that the drug, if fentanyl is prescribed, that it stays with that patient and it doesn't get out into other people that should not be using it. So the last category in the brain group would be this anticholinergics. And you can see some of this I've mentioned before. but many drugs have an anticholinergic component to them. So they're working on acetylcholine, which is, again, another one of our neurotransmitters. And many classes of meds can have an anticholinergic component. Again, many of your over-the-counter sleeping aids can be anticholinergic. This is one of those hidden ones that we need to be careful for. Sedating antihistamines that can cause drowsiness, sedation, but the thing that they do that's so problematic is they can cloud thinking and cause memory loss. So a person may be mentally fit and they start taking one of these medications, and then all of a sudden you start seeing some changes with their thinking and memory. So maybe one of the first things to do is go back and look to see, are they on an anticholinergic? And they also can be associated with urinary retention. So a lot of these, got a lot on that list. So let's move on to blood pressure. Again, we know that blood pressure meds are antihypertensives, but they're also used for other conditions. And what we're concerned about is a sudden change in blood pressure, sudden fall in blood pressure, or chronically low blood pressure can increase fall risk. And so obviously diuretics fall into that. And one thing that we need to caution our patients about on any blood pressure med is changing positions. So when they go from sitting to standing, or lying in the bed to standing up to go to the bathroom or something like that, they can experience a drop in blood pressure, but they need to do that carefully and slowly. Don't just jump up and run, because then there's going to for sure be a fall. Another compounding one is sometimes drugs that we use to improve urinary flow, particularly in men. This can lower blood pressure. So you've got dual medications there that can cause a risk for falls. So this list goes on and on and on. We have all kinds of drugs here. And just giving you some examples. Let me click through these. But there's a lot of these, and many times these are used in combination. And so sometimes when we're trying to manage someone's blood pressure or initially diagnose it, they may be put on combinations of drugs and changing doses. But once you get someone's blood pressure stabilized, then take a step back to see, are we on the best mix of drugs and the best doses? But people can be on all of these things. And the last category is those that lower blood glucose, or as they call it, blood sugar. And this is a consideration for patients with diabetes. And if the drugs that can lower glucose, not all drugs that we use to manage diabetes actually can cause hypoglycemia, but some can. But we have to make sure that our patient's blood sugar is at the right level. So this, again, is just in combination with the other drugs that they may be on, and that can put the patient at risk for a fall. So we've got the hypoglycemic agents here. So there's some other categories as well. We've got muscle relaxants, which again, these are normally prescribed after an injury or maybe for a muscle spasm or spasticity, sometimes for musculoskeletal pain. Common side effects here, you see a lot of CNS, so central nervous system effects, but patients should be cautioned to avoid drinking alcohol while taking a muscle relaxant. And hopefully these are short-term, that through physical therapy and things like that, they can move through this muscle pain without having to be on these for a very long period of time. I personally have never taken any of these, but I hear from patients that they are just profoundly, they just, quote, knock you out, you know, that they just cause pretty severe effects. And see, there's good old Valium, diazepam on there. So here's your NSAIDs, which I mentioned before. Again, some of these are available without prescription. They have all kinds of side effects as well. But if a person is taking these, that is indicative that they may have pain, and then that could cause movement disorders. So you kind of have to put the think about, why are you taking this medication? Is that affecting your mobility and putting you at risk for a fall? So we have non-prescription and we have prescription ones as well. And a lot of the concern here, particularly with these, is they can actually cause some GI effects that are not productive to the older patient. And sometimes they can affect renal function in a patient. So alpha blockers, these are the ones that what I talked about, that can change urinary flow. So, but also they can lower blood pressure. So this is a lot of information. So what can we do, and what can we do as providers and as patients as well? Know your meds and share your list with people. Talk to care providers when you can. Optimize this, so go through and look to see what's there, trying to avoid drug-drug interactions and weigh the risk and benefits. And this last line on here is been in geriatric and older adult care forever. Start low and go slow. Anytime you're changing a med, adding a med, taking a med off, start at the low dose and make changes slowly, and to see how it's going to affect your patient. So here's how can you get this list? There's the link here, the CDC website, My Medication List, and this can be downloaded, and here's an example of it. But it gives you some instructions, gives you some information here. You list your medical conditions, things that you should not use because you have allergies or maybe had a reaction to them. So fill that in. And then here, the other pages of that you can keep a list with the name, why you take it, how you're supposed to take it, who prescribed it, and then any notes to yourself that can help you with that. And I've seen you can make these homemade. I mean, I've seen a lot of these ways, and a lot of older adults are very, very into this about keeping their list of their medications. But it's always good to have on hand and have a family member also be aware of the situation. And just a couple more things as we're wrapping up. Polypharmacy, and hopefully we know that term, and poly means many, pharmacy obviously is medication. And again, this is another term that has a negative connotation with it. The definition is prescription, administration, and or use of more medications than are clinically indicated in a given patient. And so we all know with multiple medical conditions, there is the need to be on multiple medications. So polypharmacy is not always bad, but if patients are on medications that are not clinically indicated, then that's when polypharmacy becomes a problem. You might hear this term here of 5 or more medications. That came from some government oversight regulation trying to regulate drugs in nursing homes. But there really is no number of a perfect number of meds or a perfect number of how many. It's just more than are clinically indicated in a patient. So here's how once you get that list made, match your indications, why you're on it and what the dose is, and then look for multiple medications in these certain areas: high blood pressure, pain, any non-prescription anticholinergics, those with sedative side effects, or hypoglycemia. And that's what you need to focus in on. Are you on the best combination of those for you as an individual patient? So again, once you get that list, focus it down, and then go back and look to see what of these can contribute to falls, confusion, or cardiovascular problems. And that the supplement list, again, take a good look at that to make sure that you're on those for a particular need. So don't panic and do not stop taking a medication without the advice of your healthcare provider. Regularly reevaluate the need and dosage of these. And again, have information about your medications. For as healthcare providers, we can stop medications and supplements when possible, switch to safer alternatives, and then reduce medications to the lowest effective dose. And again, in older people, a lot of times they're going to need a lot lower dose than would be prescribed, say, for a 30-year-old healthy adult. So in closing, you have a lot of medications, but you need to know the list. You need to be an advocate for yourself and your patient. And your pharmacist, since I'm a pharmacist is an accessible healthcare provider that has a lot of information. And we want to avoid falls. And there's that mantra, start low and go slow, but always with the advice of your healthcare provider. Thank you.
Thank you so much, Dr. Miller. That was eye-opening. I think especially for the sandwich generation that I now find myself in, we definitely keep a list of my own mom's medication in our wallet, and it's ever changing. So this was really, really helpful and eye-opening. You have one question from the crowd. Mr. Travis Allen asked, how often must medications be reviewed when someone is taking 6 or 7 meds at a time?
All right, so how often to review when taking 6 or 7 meds? Probably a yearly basis would be good, but also if something is added or taken away. So if you have a visit with a healthcare provider and they want to add some things or change some things, or you as a consumer, as a patient, purchase something prior to purchasing that med, ask for that review to see if that med would interfere with that. I know, again, with insurance and things, sometimes they only pay for yearly visits. Sometimes they may pay for a 6-month visit, depending. But when you're making a change, or the other thing is if you notice a change in yourself, something comes on, that's different. Maybe this is a med. I always suspect the med, so go back and have it. But to directly answer the question, maybe every 6 months or when there's a change.
Thank you, Dr. Miller. That's really good advice. Okay, if there's any other questions, please feel free to put them in the chat. Otherwise, we are nearing the end of our time today. Thank you so much to Dr. Miller for sharing all of her experience and expertise. I know it is so helpful to myself and to all of you. I would also like to thank all of our attendees for joining us and the great question we had today. As a reminder, this session was recorded and it will be available on the Injury Prevention Research Center at Emory's YouTube channel in the coming weeks. If you have additional questions for our speakers, please don't hesitate to reach out to generaliprice@emory.edu. Lastly, there will be a brief survey at the end of this session with a few short questions. I think there's only 3, so it won't take a long time. We hope that you have all enjoyed each of our Falls Free Friday events this year to support Fall Prevention Awareness Month. If you missed a session or are interested in a topic, please check out the iPrice YouTube channel Georgia Falls Free Friday 2024 playlist to review our recordings. Again, I would like to thank our speaker, Dr. Susan Miller, and all of our participants who joined us today. Thank you for spending your Friday morning with us. I hope you all have a really lovely weekend.